presenting the results of a study we recently conducted towards generating a consensus on the management of COVID-19 related acute respiratory failure using a modified Delphi method. We call this the CARF Delphi study. Now, as you are all aware, the SARS coronavirus 2 has emerged as a pandemic and resulted in unprecedented pressures on the healthcare systems globally. Now, many of these patients have mild symptoms, just fever, myalgia, etc. But a small proportion of them do present to the hospital, and some of them, if they fall critically ill, do present to the ICU. Now, COVID-19 patients who come to the ICU with hypoxemia typically require some form of respiratory support. Now, whether COVID-19 causes an atypical form of ARDS still remains a matter of debate. And consequently, there has been no agreement on the management of COVID-19 related acute respiratory failure. What are the best oxygenation and ventilation strategies for these patients is still unknown. In addition to this, the impact of different treatment strategies has been variable. And there are many ongoing randomized controlled trials, but they're not yet completed. Hence, we aim to achieve expert agreement on the respiratory management of COVID related acute respiratory failure using a modified Delphi method. So, a steering committee of 10 critical care physicians across the globe actively involved in the management of COVID related acute respiratory failure was formed. I served as the moderator of this group, and there were 9 other experts who were part of this group. And Dr. Prashant Nasa was the principal investigator. And how we went about developing this survey is first we conducted a systematic search of review of literature. And we included studies that were published in English between January 1st and 3rd September. And our questionnaire was divided into 5 sections. And this included various aspects of respiratory support like non-invasive respiratory interventions, invasive mechanical ventilation, refractory hypoxemia, infection control, and weaning and tracheostomy. Now, we invited 60 global experts, and 39 of them finally were included in the survey. And we had a criteria that they had to be experts in the field of acute respiratory failure, had to have published work in the field, and they also had to have an H index more than 10. So this is showing you the geographical distribution of the countries that were represented by the experts. And as you can see, we had 39 experts from 20 countries over 6 continents. So a good distribution, both from various diverse regions, various cultures, ethnicity, and also low and high income countries. And the green shades that you see on the map, they represent the number of experts from the respective countries. Now, our Delphi survey consisted of 2 types of questions. We had multiple choice questions, and we also had a 7-point Likert scale. Now, in the Likert scale, if the score was between 5 to 7, it corresponded to agreement. If there was a score of 4, it was neutral. And if 1 to 3 was scored, then it constituted disagreement. So 2 types of questions were present for the experts to answer. And what did we consider as consensus or agreement? If more than 70% of the experts voted on a particular Likert statement, or if it was an MCQ, then more than 80% of the experts had to vote that particular statement, and this would be considered as consensus. So we tried to achieve consensus through the Delphi process. Not only consensus, but also the stability of the responses was very important between the rounds. And this was assessed between the 2 concluding rounds for each of the statements. And this was done using the non-parametric chi-square test. And if there was a p-value less than 0.05, this was considered as a significant variation or instability. And we went ahead with subsequent rounds until we achieved both consensus and stability for each of the statements. Now, this is just showing you a schematic representation of the various steps of the Delphi process. And we went through 5 survey rounds. So as you can see, initially we invited 60 experts. 39 of the experts finally took part in the Delphi process. And we had 5 rounds till we achieved consensus and stability. In the first round, we had 46 questions, which was framed using the systematic search of the literature that we did. And following this, the experts gave their feedback and they gave 533 comments, based on which we fine-tuned the questions, revised the questions, and finally we prepared 37 questions, which was put forward in round two. And only 18 of them generated consensus. In round three, we repeated the same questions. However, the language was slightly modified for clarity, and we were able to achieve 23 consensus in 23 statements. In round four, we only repeated those statements that did not achieve consensus and stability, and we were finally able to achieve consensus in 27 statements. And in round three, only the two questions that did not achieve consensus and stability was repeated, and these also achieved consensus. And finally, we had 27 statements that achieved consensus and stability following the 5 rounds. And these 27 statements that achieved consensus and stability were subsequently used to produce clinical practice points. So we had clinical practice points in various areas of care related to respiratory support. So related to awake proning and steroids. Now, the first point is that the pathophysiology of COVID-related ARDS acute respiratory failure is similar to that of ARDS. And this was almost 86% of the experts felt this. And related to steroids, the use of corticosteroids in COVID-19 could be potentially avoid the need for tracheal intubation and invasive mechanical ventilation. And of course, following the results of the recovery study, not surprisingly, dexamethasone was the preferred choice by the experts, with a dose of about 6 milligram daily for 5 to 10 days. Related to awake self-proning. Now, awake self-proning is something new that we're doing. We prone intubated, mechanically ventilated patients, but there have been studies that have shown improved oxygenation with awake proning. So experts believe that awake proning may improve oxygenation. And in addition, they said that awake proning should be initiated in those patients who require supplemental oxygen to maintain their saturation more than 90%. What about non-invasive ventilation? That is the use of pressure support and PEEP, and also high flow nasal cannula oxygen. Now, initially, there was a lot of reservation of using both NIV and HFNO because of fear of aerosol generation. However, the increased use and evolving evidence, and also better availability of the PPE, and also considering there was, constraints with the number of invasive mechanical ventilators available, more and more people started using NIV and high flow nasal cannula oxygen. What did the experts recommend? They said HFNO therapy can be used as an alternative for oxygen support, and it should be initiated when patients are unable to maintain saturation more than 90% using high flow delivery devices or with the oxygen mask, and also when there's increased oxygen requirement. And they also believe that HFNO may avoid the need for tracheal intubation and invasive mechanical ventilation in patients with COVID-related acute respiratory failure. Regarding non-invasive ventilation, the expert considered this useful only in patients with mixed respiratory failure and those with increased breathing, work of breathing. And this is fairly consistent with the recommendations also in patients, non-COVID patients. How about intubation and ventilation? The trigger for intubation. Now, there has been a lot of discussion and debate about whether the patient should be intubated early or they should be intubated late. And the expert considered the appropriate trigger for tracheal intubation when the patients had altered mental status, hemodynamic instability, and also failure to maintain the saturation more than 90% with non-invasive respiratory support. So if you see, they did not represent, this is fairly consistent with even non-COVID patients. And if you see, they have gone purely by clinical criteria rather than using the X-ray findings or the ABG, CT scan findings, etc. There was a strong 100% recommendation for lung protective ventilation to be used for all patients with COVID-related acute respiratory failure, and the targets being a tidal volume of 4 to 6 ml per kg predicted body weight, plateau pressure to be kept below 30, and driving pressure less than 15 centimeters of water. And this is similar to that of ventilation in acute ARDS. Regarding the use of neuromuscular blockade, this was the experts suggested that this should be considered only during the early phase of invasive mechanical ventilation at the time when there is patient ventilator dysynchrony. How about refractory hypoxemia? So the use of recruitment maneuvers in patients with refractory hypoxemia on invasive ventilation, mechanical ventilation, experts believe that this needs to be personalized due to the potential deleterious effect that has been well established even in non-COVID ARDS. And prone position was recommended during invasive mechanical ventilation. The experts believe that it improved oxygenation, and the duration that was recommended was for 16 to 24 hours. And this is quite consistent with the Proceva trial that was done in ARDS patients, non-COVID patients. What about the role of venovenous ECMO? And the experts said this should be considered only in patients with refractory hypoxemia or non-invasive mechanical ventilation when it does not respond to adjuvant therapies. Regarding weaning and tracheostomy, the experts suggested that pressure support ventilation trial for 30 minutes to 2 hours should be a preferred strategy for liberation. Early mobilization, the experts agreed, was beneficial in patients on respiratory support. Now, there have been concerns about, reintubating a patient following extubation, and some people in the have, preferred a delayed extubation of these patients when they're absolutely sure there's no chance of reintubation. However, the experts were recommended against delaying liberation from invasive mechanical ventilation to reduce the risk of reintubation. And even tracheostomy, there has been a lot of discussion and debate about the timing of tracheostomy. Should it be done early? Should it be done late? And what is the technique? Is it a surgical technique or percutaneous technique? What should be followed? And, following this debate, there has been a series of guidelines that have been recommended. The experts recommended that the timing of tracheostomy to facilitate weaning from invasive mechanical ventilation should be done exactly in the same way as you would do in non-COVID patients, and they preferred percutaneous tracheostomy with or without guidance, that is ultrasound or using bronchoscopy, as a preferred technique over performing a surgical tracheostomy. Now, related to infection control, now there's been a lot of discussion about aerosol generating procedures. And recently, there's also been a controversy about whether intubation is an aerosol generating procedure at all, with studies showing that they may not be aerosol generating as we thought they were. And if you see the experts, they recommended tracheal intubation, tracheostomy, bronchoscopy, tracheal extubation, bag mask ventilation, NIV, open suctioning, and nebulization and HFNO. So a lot of interventions as aerosol generating. I think they erred on the side of being more careful and labeling more procedures as aerosol generating in view of the inconclusive evidence. And they also recommended the use of airborne infection isolation rooms, the use of video laryngoscopes, and closed suction systems around tracheal intubation to prevent cross contamination. So, in conclusion, using this modified Delphi method, we were able to get agreement among experts in 27 statements. That's 73% of the statements on the respiratory management of COVID related ARF. And from these, the clinical points that we have generated, clinical practice points, they address very important decisions on patient management in areas where the evidence is either absent or limited. And we believe that these will be very useful for the clinician until such time that robust evidence through randomized controlled trials is generated. And of course, further studies are needed to confirm the beneficial effects of these interventions on meaningful clinical outcomes. Thank you.